Welcome to this video. In this video, we're going to discuss the drug treatment of essential hypertension. To begin with, however, let's just have a brief summary of what essential hypertension is, what some of the major risk factors for essential hypertension are, and what some of the major complications of essential hypertension are, and then we'll go on and discuss the drugs that are used to treat it. So firstly, what is essential hypertension? Well, we have to begin by asking, what is hypertension? So hypertension is the fancy medical term for blood pressure that is too high, and the definition of elevated blood pressure is blood pressure that is greater than or equal to 140 over 90 millimeters of mercury. And of course, the top number here, 140, is the systolic blood pressure, and 90, the bottom number, is the diastolic blood pressure. And remember, the ideal textbook blood pressure is around 120 over 80. Now, in order to qualify for this diagnosis of hypertension, you actually only need one of the two numbers to be beyond the threshold that we've set here. So to say this concretely, if only one of the two numbers is greater than the threshold set here. So let's say the systolic blood pressure is greater than 140, so let's say 150, but the diastolic blood pressure is less than 90, so let's say 87, so 150 over 87, that still counts as hypertension because one of the numbers is all you need to be above the threshold in order to get the diagnosis. Equivalently, if the systolic blood pressure was less than 140, but the diastolic blood pressure was greater than 90, so let's say 136 over 96, that would also count as hypertension. So I want to drill that into your mind. Only one of the two numbers has to be greater than the threshold. Of course, if both numbers are greater than the threshold, that absolutely counts as hypertension, but that's not necessary. Only one has to be greater in order to count as hypertension. So that's what hypertension is. What is essential hypertension? So essential hypertension means that the hypertension is idiopathic. We cannot find another medical disease that the individual has that is causing their hypertension. So there are many different diseases that can give rise to hypertension as a manifestation. So in particular, diseases of the kidney, they can quite often lead to hypertension. That sort of hypertension would be called secondary hypertension because it is secondary to another medical disease. So we have a good explanation as to why the individual is hypertensive in that case. In essential hypertension, which is also called primary hypertension or idiopathic hypertension, we do not have another disease that individual has that we can blame their hypertension on. Instead, we do not know the reason that their blood pressure is too high. And essential hypertension or primary hypertension is far more common than secondary hypertension. So most people who have elevated blood pressure, they will have essential hypertension rather than their hypertension being because of some other medical disease. And there are a huge number of biomedical scientists all over the world that are working on trying to understand why people get high blood pressure for, at the moment, an unexplained reason. Of course, there will be a reason behind it, but we just don't know that at present. And there are a huge number of scientists trying to figure out why so many people are hypertensive, and they're continuing to work on this, so watch that space. But at present, it is considered idiopathic. We do not know why they are hypertensive. So, what are some of the major risk factors then for essential hypertension? Well, there are absolutely loads of risk factors. The two major ones that you need to be aware of are age and being overweight. So as you get older, you are far more likely to have essential hypertension. It is very unusual for young people to have essential hypertension. It's much more common in older people. So most of the people that you will meet with diagnosis of essential hypertension will be over 50. So age is a major risk factor. You're much more likely to have unexplained elevated blood pressure as you get older. Now, of course, you can't do anything about your age, but one of the major modifiable risk factors for essential hypertension is being overweight, having an elevated BMI. So if you are overweight, this also makes you far more likely to have essential hypertension. And if you do have essential hypertension and you're overweight, one of the key things that you can do to try and bring your blood pressure down is lose weight. And indeed, I've met many people who have had this diagnosis of essential hypertension. They've been overweight, they've lost weight, and then their blood pressures come back down to normal levels, so they've effectively cured themselves of this ailment. So being overweight is another major risk factor, and this of course is modifiable. So if you do have a patient with essential hypertension who is overweight, advise them to try and lose weight in a sympathetic manner, of course, because it is incredibly difficult to lose weight, but it can cure this, so it is extremely important to advocate that. So those are some of the major risk factors. Now let's just talk briefly about complications before we go into drug treatment. So why do we get so fussed about people having too high blood pressure? Well, the reason is that having too high blood pressure for a long period of time can damage arteries of the body. And it can damage arteries of the body in two major ways. The first is through atherosclerosis, so narrowing of the blood vessels, and the second is through aneurysm formation, so dilation of blood vessels. When atherosclerosis occurs in the coronary arteries, that of course leads to coronary artery disease that, worst case scenario, can lead to heart attacks that can be fatal. When atherosclerosis occurs in the carotid arteries or the cerebral arteries, it can lead to strokes. It leads to cerebrovascular disease. And again, strokes can be fatal or extremely debilitating. Atherosclerosis can occur in other places and be significant as well. It can occur in peripheral arteries in the legs and lead to peripheral artery disease and claudication and potentially limb ischemia and, worst case scenario, your leg infarcting and having to be amputated. Atherosclerosis can also affect the renal arteries and lead to renovascular disease. It can affect the mesenteric arteries and lead to mesenteric vascular disease. So atherosclerosis can affect blood vessels all over the body, and it damages the blood supply to the end tissue. It can also lead to acute infarction of that tissue if atherosclerotic plaques rupture and thrombosis occurs over the top, which can completely occlude the blood vessel. So atherosclerosis is not good and can lead to very serious complications that can potentially be deadly or extremely debilitating. Aneurysms can occur again all over the body. Serious places for them to occur are in the aorta, the massive blood vessel of the body. If an aortic aneurysm ruptures, it can lead to catastrophic hemorrhage. Another serious place for aneurysms to occur is in the brain, intracranially. If aneurysms in the brain burst, that can lead to a hemorrhagic stroke, which again can either be fatal or extremely debilitating if it's not fatal. So atherosclerosis and aneurysms are very bad things, lead to very bad consequences, and that is why we want to bring people's blood pressure down, because having too high blood pressure results in these two things happening to your arteries. So there we go, that's what essential hypertension is. Those are some of the major risk factors for it, and we've also discussed some of the major complications of it. Let us now discuss how we treat essential hypertension. And the way we're going to do this is we're going to work through the drugs in the order that they are actually trialled clinically. So there is a hierarchy for the treatment of essential hypertension. There are first-line drugs, and then there are second-line drugs, and so on. And we work our way through this ladder of drugs. So we're going to start off with the first-line treatment, the first drugs that you should go to. So there are two classes of drugs that are first-line, and which one you use depends on the patient that you're dealing with. So the two main classes of drugs are ACE inhibitors, which I'm going to abbreviate down to ACE-Is. So ACE, of course, stands for angiotensin-converting enzyme, and the I stands for inhibitors. So this is one major class of drugs. And then the other major class of drugs is CCBs, which stands for calcium channel blockers, which are drugs that are going to inhibit the activity of calcium channels in smooth muscle cells. Now, how do you decide then whether you're going to start off with an ACE inhibitor or a CCB? Well, the way you do this is it's determined by the patient's age and also by their race. So if the patient is under 55 and they are not black, so not Afro-Caribbean, then you start with an ACE inhibitor. If, on the other hand, they are over 55, so greater than or equal to 55, or they are Afro-Caribbean, then they should be started with a CCB. And the reason for this is that multiple studies have found that in people who are under 55 and not Afro-Caribbean in race, ACE inhibitors are more effective at bringing down blood pressure in essential hypertension than CCBs, whereas in people who are over 55 or who are Afro-Caribbean race, CCBs are more effective than ACE inhibitors at bringing down essential hypertension. So we have this separate treatment schemes simply because they are more effective in these different categories. So let's now give some examples of ACE inhibitors and CCBs. So let's begin with ACE inhibitors. So the names of all of the ACE inhibitors end with the suffix pril. And by far and away, at least in the UK, the most important ACE inhibitor to know the name of is ramipril. Other examples that I won't write down: enalapril, captopril, lisinopril, perindopril, quinapril, trandolapril. You can see that they all end in the suffix pril. So if you see a drug that ends in pril, it is most likely an ACE inhibitor. In the UK at least, the most commonly used one is ramipril. So that is the one that above all the others you need to know the name of. CCBs now. CCBs all end in the suffix dapine. And again, I'm just going to write down one name, which is again in the UK the most commonly used one, and that is amlodipine. Other examples of CCBs: flodipine, you see that used occasionally. Lercanidipine, you also see that used quite a lot. Nifedipine is also a good example to recognise the name of. It's a little bit archaic, but it is a classical example of a CCB, not commonly prescribed anymore, but you do sometimes see it in use. So ACE inhibitors all end in the suffix pril, CCBs all end in the suffix dapine. And if you're going to learn two examples, ramipril is the ACE inhibitor to learn the name of, and amlodipine is the CCB to learn the name of. Now, let's just briefly discuss the mechanism of action of these categories of drugs. So let's talk about ACE inhibitors first. So ACE inhibitors work by inhibiting the angiotensin converting enzyme. That is an extremely important enzyme in a system known as the Renin-Angiotensin-Aldosterone system, or the RAS system for short. So ACE inhibitors inhibit, so that is the symbol for inhibit. They inhibit the RAS system, so this stands for the Renin-Angiotensin-Aldosterone system. Now, that means that the activity of this system is going to come down when you give an ACE inhibitor. So, I'm not going to go through the entire Renin-Angiotensin-Aldosterone system. Instead, what I'm going to tell you is what is the overall function of this system, what is the big picture, and why is reducing the activity of this system useful if you want to bring down blood pressure. So, the purpose of this system revolves around the kidneys. It is a system that monitors and regulates the function of the kidneys. And the aim of it is to maintain blood volume. I'm going to say that again because that is so important to understand. The Renin-Angiotensin-Aldosterone system exists. It is a physiological system to maintain blood volume. Now, of course, every day you are consuming fluid. You drink fluid, and there's fluid in the food that you eat. And this is being absorbed by the digestive system and going into the bloodstream. If you are going to maintain a constant blood volume, then you need to get rid of that fluid, and the major way that you get rid of that fluid is through the kidneys. Now, of course, there are the insensible losses. You breathe fluid out because you humidify the air that you breathe in, and you also sweat fluid out, but we're going to overlook that. We're going to concentrate on the urine as the major way that you get rid of fluid. This means that depending on the amount of fluid that you have consumed in a day, you need to modify the volume of urine that you are producing so that it equals, as I say, we're overlooking the insensible losses, so that it equals the amount of fluid that you are taking in, so that blood volume is maintained, so that you have an equilibrium. The renin-angiotensin-aldosterone system is the system for regulating this. It tells the kidneys basically how much urine to produce, what volume of urine to produce. And it is doing this by looking at blood volume. So let me spell this out. If blood volume goes up, so let's say you have a big glass of water, that raises blood volume. What will then happen is the renin-angiotensin-aldosterone system function goes down, and it has a baseline function. Normally, it's active at a low level and it has a baseline function, and it is telling the kidneys to produce a normal level of urine. If blood volume goes up largely because you have had a large glass of water, what will happen is the level of activation of the system will go down below what it is at baseline, and that then tells the kidney to start producing a greater volume of urine than it would at the baseline function, so that you can get rid of this excess fluid. In contrast, let's say you've been on a long walk on a hot day and you've sweated out a lot of fluid. Now blood volume might be too low. Let's say you didn't think to take a bottle of water with you either, so blood volume is now getting a little bit on the low side. What will then happen is this system's activity will go up above the baseline function, and that will tell the kidneys, no, produce lower volume of urine, go below the normal baseline urine production volume, conserve fluid, concentrate all the waste products that we're excreting in the urine into a smaller volume because we need to conserve the fluid. That is how this system operates. It's all about adapting how much urine the kidneys are producing so that it reflects what is happening to blood volume. And if blood volume is too high, then it tells the kidneys to produce more urine by reducing its activity below baseline. And if blood volume is too low, then it increases its activity above baseline and tells the kidneys to conserve fluid. So it's all about trying to maintain blood volume. So I'll just put a little arrow here. So the major thing that it does, and there are two major things, I've discussed one of them now. One of the major things it does is it maintains blood volume, and the more active it is, the more fluid you are conserving. The less active it is, the less fluid you are conserving and the more urine you are producing. So one thing that it's important in doing is maintaining blood volume. The other thing that it does is it controls total peripheral resistance. So let me just write a very important formula now down for you. So you probably remember, from basic cardiovascular physiology, that there is an equation that says that blood pressure is equal to cardiac output times total peripheral resistance. And remember, the way that you arrive at this formula is it's basically just the plumber's first law, that flow, which is cardiac output, is equal to the pressure difference, blood pressure, divided by resistance. But we've just brought the resistance up here to make this formula that blood pressure is equal to cardiac output times total peripheral resistance. And this makes total sense. If you increase cardiac output, of course, blood pressure is going to go up. And if you increase total peripheral resistance, of course, blood pressure is going to go up. So, if you want to bring up blood pressure, there are two ways to do it. You can either increase cardiac output or you can increase total peripheral resistance. Now, coming back to what I was talking about, the renin-angiotensin-aldosterone system, remember, it's all about responding to changes in blood volume. If blood volume is too high, then by Starling's law of the heart, cardiac output will go up. Remember, Starling's law says that if you fill the heart with more blood, the amount of blood that it will eject out gets bigger, the stroke volume gets bigger, and that's not trivially obvious. It sounds trivially obvious that if you fill the heart with more blood, it will pump more blood out, but it's not, because that means that the heart is actually going to have to generate more energy if it's pumping more blood out, so it's not as trivial as it sounds. Nevertheless, it is true that if you fill the heart with more blood, it pumps more blood out, stroke volume goes up and cardiac output goes up. So if you raise blood volume, that is of course going to fill all blood vessels of the body more, including the heart. So stroke volume will then go up by Starling's law and cardiac output will go up. So raising blood volume, if blood volume is in a raised state because you've just drunk a glass of water, cardiac output will be up, and therefore this would result in an increase in blood pressure if we didn't bring down total peripheral resistance. And conversely, if blood volume was too low, cardiac output's going to be reduced and blood pressure would be reduced unless we brought up total peripheral resistance. So this system, which is measuring blood volume in order to determine its activation state and acts on the kidney to try and conserve blood volume or match the amount of fluid that we are retaining to try and fix blood volume, it would make sense for this system to also be linked to controlling total peripheral resistance, i.e. the constriction state of all the little arterioles of the cardiovascular system, and that is exactly what it does. So it also has a role in determining total peripheral resistance. And this is, if you know anything about the Renin-Angiotensin-Aldosterone system, you'll know that it's aldosterone that influences the kidney's conservation of fluid, and it is angiotensin 2 that influences all the little arterioles of the body and changes their constriction status to alter total peripheral resistance. So let's talk through this again. Let's say blood volume is now below what it should be. We know then that the Renin-Angiotensin-Aldosterone system goes up. It's trying to tell the kidneys for aldosterone to conserve fluid to try and bring blood volume back up, but it's also going to cause an increase in total peripheral resistance. It's going to constrict all the little arterioles to bring up total peripheral resistance, and the reason for that is that it's also helping in the short term to maintain blood pressure. Because if blood volume has gone down, then to maintain blood pressure we need to bring up total peripheral resistance. So this system, not only does it influence the kidneys, but it also influences all of the little arterioles of your body and influences their constriction status. In contrast, if blood volume is too high, we know this system's activation status goes down. It tells the kidneys you can produce a huge volume of urine, but it also tells all the little arterioles, when the system's activation is down, it tells the arterioles you can relax, you can lower total peripheral resistance, because if blood volume is high, cardiac output will be high, so if we want to keep blood pressure normal, we need to bring total peripheral resistance down. So in summary, the Renin-Angiotensin-Aldosterone system, its major function is to conserve blood volume by changing the urine output of the kidneys, but it also influences the constriction status of the arterioles to change total peripheral resistance in order to maintain blood pressure in the face of changes to blood volume. Now, this makes it an ideal target if we are trying to lower blood pressure. This is why ACE inhibitors are so good. If we use an ACE inhibitor, then we inhibit this system's vasoactivity. So remember, this system has a baseline activity. Even if blood volume is perfect, it's ticking along at a baseline level. And this baseline level of activation is telling the kidneys how much urine to produce, and it's also telling the arterioles how vasoconstricted to be. If we inhibit the system by giving an ACE inhibitor, such as ramipril, we bring the system's activation down. And we know what happens if we bring the system's activation down. That is equivalent to if blood volume was up. That then will tell the kidneys that they can produce more urine, so we'll excrete more fluid, we'll bring blood volume down. So I'll put this here. If we give an ACE inhibitor, the RAS system is inactivated. That will bring blood volume down, and it will also bring total peripheral resistance down, because remember we said that inhibiting this, when this is at a lower level, it's going to bring total peripheral resistance down by telling the arterioles to vasodilate. And of course, this is going to fantastically influence blood pressure, because if blood volume comes down, that leads to cardiac output coming down. If total peripheral resistance comes down, this part of the equation comes down, and therefore both of these components are going to be reduced by giving an ACE inhibitor, and therefore blood pressure is going to come down. So that is how ACE inhibitors influence blood pressure. They reduce blood volume and they reduce total peripheral resistance. And they work by reducing the renin-angiotensin-aldosterone system to below the baseline level. So that is why this system is such a fantastic target for antihypertensive medications, and they are incredibly effective antihypertensive medications. Whew, that was a complicated explanation. Thankfully, CCBs are a much, much easier explanation. These quite simply work on calcium channels in the vascular smooth muscle cells around arterioles, and therefore they directly cause relaxation of those vascular smooth muscle cells, and therefore they lead to vasodilatation of all the arterioles, the tiny little arterioles. So they cause vasodilation directly, and therefore they will lower total peripheral resistance. So they bring just this part of the equation down here, and that's how they lower blood pressure. So that's a much simpler explanation. They act directly on the vascular smooth muscle cells around the arterioles that control the constriction status of the arterioles and cause them to relax, cause the arterioles to dilate. That lowers total peripheral resistance, and that's how they lower blood pressure. Now, we'll have a break in a moment, but just a few things to add. ACE inhibitors can have a classic side effect, and that is because the angiotensin converting enzyme doesn't just convert angiotensin 1 to angiotensin 2 as part of the renin-angiotensin-aldosterone system. It also breaks down another chemical in the body called bradykinin. And if you give an ACE inhibitor to inhibit the ACE enzyme, that can result in bradykinin levels in the blood going too high. And when bradykinin levels go too high in the blood, that can cause a cough, a chronic cough. So this is one of the absolutely classic side effects of ACE inhibitors. They can cause a chronic, persistent cough that affects the person all day long and can be really annoying. If someone comes in complaining that they have a cough and they are taking an ACE inhibitor, then this is one of the things you need to consider, and you need to consider taking them off the ACE inhibitor. Now, what do you do then? Well, you can put them on another type of drug that also inhibits the renin-angiotensin-aldosterone system, but works more downstream. It works by blocking the activity of angiotensin 2, and these are called the ARBs. And that stands for angiotensin receptor blocker. So if someone is having the side effect from an ACE inhibitor of a chronic cough, you should switch them over to an ARB. And the only people who should be on ARBs are people who cannot tolerate ACE inhibitors because of the cough. So ACE inhibitor is first line in people who are younger than 55 and not black. But if you get the side effect of a chronic cough from them, then you should move over to an ARB, which does the same thing but doesn't give rise to the cough. Examples then of ARBs, there are 3 major examples, and unlike with ACE inhibitors and CCBs, where there is one major example that above all the others is prescribed, there are 3 major ARBs that I would say are all roughly prescribed equally to one another. So I'm going to write them all down. So candesartan is one, losartan is another, they all end in zartan, and the final one is irbesartan or irbesartan. So those are the 3 major angiotensin receptor blockers: candesartan, losartan, irbesartan. So remember your physiology. Angiotensin 2 is created by the angiotensin converting enzyme, and it then acts on the zona glomerulosa cells of the adrenal glands to produce the aldosterone by acting on a receptor that is the angiotensin receptor. It also acts on the vascular smooth muscle cells around the arterioles by acting on an angiotensin receptor. So by giving these drugs that are going to antagonize that receptor, we are going to still have these exact same effects of ACE inhibitors. We're still going to inhibit both of the effects of the renin-angiotensin-aldosterone system, both the effect on the kidneys and the effect on the arterioles, but we're doing it more downstream, and that stops this side effect of bradykinin buildup and the chronic cough. So be aware of the ARBs that you will see a lot of people on because they have had the side effect of a chronic cough from ACE inhibitors. Okay, so there we go. That is the first tier of drug therapy for essential hypertension. We'll have a break here, and in the next video we'll talk about further drugs, starting with thiazides.